So the time starts now. The first scenario is on overactive bladder. A 50-year-old woman presents with history of frequency both day and night time. Nighttime she gets up at least twice. Daytime the frequency goes even up to 10 times. So how will you evaluate her?
Right. So I will see this patient in the functional urology clinic. Would like the patient to have a urine dip test, frequency volume chart completed for 3 days, and IC-IQ overactive bladder completed. The patient has symptoms of overactive bladder storage symptoms. Would like to take history, do examination, and then arrange for investigations. In the history, I would like to ask the patient about, she has storage symptoms already, would like to know if she is incontinent during having urge incontinence. That would be quantified regarding severity by number of continence pads, and that's the symptom bladder. Also would like to ask about any voiding symptoms. Would like to ask about her fluid intake, bowel symptoms, manual dexterity, sexual history, medical history, including any medications taken for this condition, and also the surgical history. And if there is any neurological signs and symptoms. Then we'll proceed to examination in the presence of a chaperone. Will assess her body mass index, palpate the abdomen looking for palpable kidneys, palpable bladder. Will do a pelvic examination looking for any signs of hypoestrogenization. Will do a stress test looking for any signs of stress incontinence. Assess for pelvic organ prolapse in supine and left lateral position using Sims speculum. Assess the vaginal tone, and will do neurological examination in the presence, and if she has any neurological signs and symptoms. And then I will proceed to investigations. And in the investigation, we've done a urine dip test. We'll consider the patient for a flow rate test and post-void residual, and then we'll take things from there.
Okay, so you informed me about questionnaire. Can you explain the questionnaire further?
So IC-IQ overactive bladder, that questionnaire contains questions about the frequency, urgency, and nocturia, and urge incontinence.
Okay, so how will you instruct her to complete the questionnaire?
So the patient would need to complete the questionnaire, preferably before she attends the clinic or while she is in clinic. The questionnaire will assess the symptoms of the patient for the last 4 weeks.
Okay, so what are all the questions in that?
The questions are regarding the frequency, how many times she is passing urine, symptoms of urgency, and nocturia, how many times she passes urine at night.
Okay. Our questionnaire shows that she's quite symptomatic and she's also quite bothersome. And examination-wise, her weight is say 105 kg. Other than that, she's still menstruating, some perimenopausal symptoms. There is no signs of any hypoestrogenism, etc. So how you can proceed further?
Okay, right. So basically, I would like to start my management by non-surgical techniques. We'll give the patient an advice with regards to her fluid intake, trying to reduce any irritant fluids like coffee or fizzy drinks. We'll give her an advice with regards to reducing body weight and also bladder training, and consider her for pelvic floor muscle exercise.
Okay, what is the evidence for the weight loss, weight management?
Weight loss can be helpful in patients with continence. We know that it's mainly can be helpful in patients with stress incontinence. However, as a part of general health, and it can have some role in the control of overactive bladder symptoms.
Okay, you said about bladder training. How will you advise her?
So, bladder training or pelvic floor muscle exercise. Regarding bladder training, this is a cognitive controlled kind of bladder training, trying to gradually increase the interval between voiding times. Regarding pelvic floor muscle exercise, that would be preferred to be done under supervision of a physiotherapist. Needs to be done for at least 3 months. In this condition, it helps to provide muscle relaxation and strengthening of the pelvic floor muscles done by 8 contractions of pelvic floor 3 times daily. Usually we ask the patient to perform sustained contractions with short pull-ups.
Okay, so what will you advise your patient now?
Right. So we'll advise the patient with regards to these instructions, and we'll arrange for a follow-up appointment in around 4 to 8 weeks to reassess the symptoms, and then if she's not improving with non-surgical or non-medical techniques, then I would consider her for medical treatment.
Okay, so what medical treatment you will advise? Let us assume that she is having not much improvement with the lifestyle changes.
Okay, right. So regarding the medical treatment, I will consider her on anticholinergic treatment. Usually, as per NICE guidelines, we start with oxybutynin, which is antimuscarinic treatment that helps to relax the detrusor muscle, increasing the functional bladder capacity, and reducing the intravesical pressure. I will counsel the patient regarding this treatment. Will tell her the success rate about 70%. Will counsel the patient with regards the side effects of the treatment, and the contraindications. Side effects would involve dry mouth, dry eyes, blurring of vision, tachycardia, potential arrhythmia, and constipation. Will ensure that she doesn't have contraindications like intestinal obstruction, inflammatory bowel disease, or closed angle glaucoma.
Okay, so what is the dose oxybutynin you will advise her?
I will advise her to start on 2.5 milligrams twice daily.
Okay, so when are you going to review her?
So I will review her again in 2 months, and then we'll reassess her symptoms by history taking and completing the questionnaire.
Okay, so if she's not improving with oxybutynin, what is your next choice?
Right. So next choice would be another medical treatment in the form of mirabegron, which is a beta-3 agonist that also helps to provide the detrusor muscle relaxation without affecting the bladder contractility. Also, success rate is similar to the anticholinergic medication. However, it works with a different mechanism of action. I would like to ensure that the patient has controlled blood pressure, as with regards the side effect of the treatment is uncontrolled blood pressure, and also severe kidney failure and liver failure.
Okay, what is the dose you will start mirabegron?
Right, so in the presence of adequate kidney and liver function, I would start with 50 milligrams once daily.
Okay.
And I'm aware that some urologists probably consider starting with 25 milligrams and increase the dose to 50 milligrams.
Yeah. So let us again proceed further. She's not responding well to mirabegron, or the GPS diagnosed her to have new onset hypertension, hence it is discontinued. What is the next choice for her?
Right. So the next step in the presence of failure of medical treatment, then the next step would be invasive treatment in the form of Botox injection. In our trust, we would consider the patient for urodynamics study first, do it looking for evidence of detrusor over activity, and then consider the patient for intravesical Botox injection, 100 international unit, either under local anesthesia or general anesthesia.
Okay, it's time's up. We'll stop there. How do you think you performed?
I was a little bit hesitant, but I think I'm going with the logical steps of management. Maybe I wasn't quite sure about the ICIQ Overactive Bladder Questionnaire and the evidence of weight loss. However, I feel like confident even if we carry it out further with the scenario.
Yeah, I agree. I mean, this scenario can happen in two ways. Sometimes they can complete at medications itself, because that itself, evaluation and medications takes good amount of time. And then sometimes they will go for the surgical options and refractory OAB. So this scenario is complete. So don't worry, that don't think that you have not completed the scenario. The scenario is complete. The few things to add are any symptoms or any presentations like this in many tables, even in men with LUTS like storage symptoms or voiding symptoms, you need to bring in red flag signs like presence of hematuria, prolapse, previous incontinence surgery, any pelvic mass, any fistula, double incontinence, etc. So you haven't brought in the red flag signs. And also you need to spend another maybe 10 seconds extra on her previous medications, because she may be on medications like diuretics, which may have a very big reason for the symptoms. You said you will do both flow rate and post-void residue. There is not much evidence behind flow rate in a woman, because the only reason it can be used is something like a urethral stricture or narrowing, which is quite rare in this scenario. The presentation will be entirely different. Patient will be having straining to pass urine, weak stream, etc. Here the patient's symptom is mainly frequency. So there is no real need for flow rate. Some examiners may be flexible, but some examiners may be very picky to pick what is the evidence behind flow rate, and you may try to substantiately prove yourself, and that will be loss of time and loss of mark. As you correctly said, ICIQ, you should be a little bit more confident. Like you should be able to even tell quickly the 6 questions in that. First question is just the date of birth. Second question is the frequency. And second question is whether the patient is a male or female. The third question is the frequency. The third question has 3B, which is the bothersomeness. And then so like that, the fourth question is a nocturnal frequency. Again, 4B is again bothersomeness. And fifth question is the urgency, and 5B is the bothersomeness again. And the sixth question is there any leak? And 6B is the bothersomeness. Very easy to remember. So first date of birth, second male or female, third will be daytime frequency, fourth will be nighttime frequency, fifth will be urgency, sixth will be incontinence. 3, 4, 5, 6 has got another question like 3B, 3, 4B, etc., which is bothersomeness. So it's quite easy to remember. So please do remember the ICIQ. This will really push your mark, because many people will struggle. When you are able to bring the ICIQ questionnaire, that will be really a good one. You should bring the Bowes Overactive Bladder information leaflet, quite a detailed leaflet. I know you will be easily bringing out Bowes leaflets whenever you are advising a procedure, but you can bring in even for the disease conditions also. So have a good habit of bringing Bowes OAB leaflet. Yes, regarding the weight loss, any patient with BMI more than 30, there is a good evidence to support that weight loss will result in improvement of the symptoms. Then other things, as you said, fluid management, bladder training, etc. Regarding the bladder training, we need to do at least for 6 weeks. I think you said 3 months. We should at least do 6 weeks, and if it's not working in 6 weeks, you can say it's not working and we can take it further. When you say oxybutynin, it should be an immediate release medication. The other nice approved anticholinergics are oxybutynin immediate release, tolterodine immediate release, and darifenacin once a day. So try to bring all three medicines, but you can say I will prescribe oxybutynin, nothing wrong in it. You can even add to that and say with the present practice, because of the better side effect profile, you can even say solifenacin, nothing wrong in it. So don't be very stuck theoretically, because end of the day after finishing the exam you will come back to the practice and do only solifenacin. So in the exam your presentation should be nicely weighted with the knowledge, but there should be also practicality. So if examiner asks you what is your choice of medicines, you can say, as per the NICE guidelines, I prefer oxybutynin immediate release, tolterodine immediate release, or darifenacin once a daily preparation. But in my daily practice, due to better side effect profile, I will also consider solifenacin. Nothing wrong in it. That's a perfect answer. The examiner will be happy that your knowledge is good and practically also you are sound. You brought in mirabegron correctly, and you need to say the contraindication of cognitive dysfunction for anticholinergics. You haven't brought cognitive dysfunction. Mirabegron has the possibility of palpitation or increase in blood pressure, but in the anticholinergics you mentioned palpitation. You can go through the video again when I'm sending you the link. So you mentioned palpitation in anticholinergics, which is not so. And you can say oxybutynin, tolterodine, and darifenacin as a first line anticholinergics, and you can say solifenacin as a second line. That's another way to bring solifenacin. Mirabegron, you're correct, 50 milligrams. If there is a liver or renal dysfunction, 25 milligram. When you're discussing mirabegron, the side effects you brought in blood pressure, but apart from that, nasopharyngitis and UTI. These are the other two common things which you need to explain. So make your answers a little bit complete there. Before heading towards the urodynamics or any like Botox, etc., try to bring in Synergy study, which is a nice study which got Synergy 1 and Synergy 2. Synergy 1 as the combination of solifenacin 5 mg with mirabegron 25 mg, or solifenacin 5 mg with mirabegron 50 mg, and they found very good improvement when there is a combination treatment when compared to the monotherapy. Synergy 2 is the long-term safety and efficacy of the same combination, and again it showed that the outcome is good, well tolerated for 12 months. So remember the study Synergy. It's not very important, but I always like people quoting some studies here and there, maybe one study in every table, so that that will make sure that your marks are definitely adequate or you are heading towards very, very safe margins. Okay, after this feedback, anyone in the group has any questions up to this scenario? Don't go outside the scenario. In this scenario, any questions? Okay, if there is no further questions in this scenario, we
Sorry,
will...
I had a question.
Yeah.
Sorry. Could you tell us the evidence for the BMI of 30? I know it's mentioned in the NICE guidance, but I'm not sure about the evidence.
There are some evidences. Possibly I will send it in the WhatsApp group, but the evidence is if the BMI is more than 30, advising weight management is good. At least for the exam, you should know this. So there are two groups of people, overweight and obese people. Okay, so it is good for both the groups, but those who are obese has a definite improvement in the symptoms compared to overweight. So the advantage in overweight people going for weight management is minimal, but it works for both. Definitely you need to say the patient will need overweight or obese weight management if the patient is in that category, especially the patient what we are discussing.
Okay, the other thing is Ahmed mentioned the dose of oxybutynin. You said immediate release, but I'm not sure it's 2.5 twice daily. Is it for adults?
We can give 2.5 twice daily. It's available in immediate release, and slowly we can titrate the dose to higher doses if the patient's side effect profile is okay.
Right, okay.
We can increase the dose. While solifenacin and all, it's mostly fixed dose.
Okay.
Okay?
All right.
Good. We will conclude this scenario.